and bring back to the stage Dennis Lyons.
Great. Thank you very much, David. And that was certainly a hard act to follow, but we'll do the best we can with with our next topic. It's a new one this year. As some of you may know, I represent the Mass Independent Pharmacists Association here in Massachusetts. So I thought it would be helpful to give a little presentation today on what has been happening at the State House in terms of state-based legislation. I don't do too much in the federal, but I think that this particular year has been an interesting one for pharmacists and maybe an eventful one as things move forward and play out. The learning objectives. I'm going to explain the difference between legislation and regulation. I think that my previous speaker at the Board of Pharmacy did an excellent job of this. And really what I'm going to do is really illustrate how that plays out in the real world. Also identify pending and past legislation impacting pharmacists in Massachusetts. Again, things that have happened in the past have relevance now to what's going on in our current situation. We're going to review existing law and regulations that have changed the scope of practice. We'll talk a bit about scope of practice legislation and where it's been and where it's going and what kind of impacts there are. And also identify specific strategies and actions to be taken by pharmacists to affect the legislative process. What can be done by pharmacists to help in their own profession. I have no financial relationship relevant to the content of this CPE activity. However, as I mentioned before, I do represent the Massachusetts Independent Pharmacists Association, MIPA, before the Massachusetts legislature. So as a result of that, I'm sure that some of my opinions in terms of the impact and general reflection of the legislation may be tainted a bit, but certainly within the framework of the people I represent, we certainly have our opinion in terms of what legislation is, what it means, and what's more important than the other thing, I guess. I get to start the discussion, I guess we have to really look at what some people call the scene of the crime. And that is really what is the legislature, what is it made up of? In Massachusetts, we have two chambers, the House of Representatives, the Senate, and they are what's called a bicameral organization. Cameral is the Latin word for chamber. So it's bicameral, two chambers. Some states just have an assembly, they just have one. In Massachusetts, we have two. And the third branch is the executive, and that's the governor. Again, Massachusetts has 160 members of the House. And if you go on the state website, masslegislature.gov, there's an interactive map that you can click on that map, and you can find out just click on your town, and you can find out who your state representative and your state senator. It's very easy to do. It's very easy to identify. And I certainly would recommend everyone become familiar with these people, because they have an enormous influence on your practice as pharmacists. There's, as I said, there's 160 members of the House, and we have in Massachusetts a super majority, and that is of those 160 members, 134 of them are Democrats, 24 Republicans. So there's a huge advantage that the Democratic members have over Republicans. In the Senate, it's even worse, really. There's 36 Democrats and there are only 4 Republicans. And as a result of that, in Massachusetts, most of the conflict is not between the Republican and the Democratic Party. Most of the conflict really is between the House and the Senate. The Senate is a body that's a bit more liberal. So things on the liberal side tend to percolate through the Senate, whereas the House of Representatives more conservative, more business focused, where the Senate is more progressive, more socialistic in terms of its programs, its the legislation that it moves on. The legislative session, it's a 2-year period. It changed over to this, I would say, about 10 years ago. And what that means is bills that are filed at the beginning of the first year, which in the current session would be 2023, they're filed generally in January, and they will last essentially in the process. The session will last until December 31st, 2024. So this year is the second year of the 2-year session. And on July 31st, 2024 is the last day of formal sessions. So even though a bill may last in the session until the end of the year, December, oftentimes, if it's not acted on by July 31st, it's very difficult to move that bill. We had this past year, a big controversy going on because, again, July 31st, 2023, that was the end of formal sessions, and the legislature was trying to pass, it was really, very routine legislation, but all it takes after July 31st is for one member of the legislature to object during what they call informal sessions. And if that happens, then the bill can't be moved forward. So what they will generally do from July 31st to the end of December is they'll name bridges after people, or they'll, give a pension to somebody in a particular town. Very controversial stuff. But if there's a bill and one person objects after July 31st, then the bill can't pass. And there's a series of things that they can do, but in general, that's the deadlines. It's again a 2-year session. Starts the first year. That's when a bill is filed. There's no filing. There was no filing this January, so the only time you could file a bill is January 23rd. If you didn't get it in by then you have to wait till after December 31st, 2024. Then, of course, there's always exceptions. They suspend the rules, and they can take and do a late file bill. But the late file bills have a very, very limited scope that they could pass. There are currently 7,000 bills pending before the legislature, and that was really as of January 2023. Probably 100 will actually directly impact the practice of pharmacy or insurance coverage for pharmacy. The major themes in this session, amongst those 100 bills, there's about 60 PBM reform bills. There's about 30 that are scope of practice, and then there's 5 that are related to payment for pharmacy services. So it's a pretty active year in terms of pharmacy legislation. Key members of the legislature, obviously Governor Healy, Maura Healey, Democrat, first openly gay woman to be elected as governor, former Attorney General, and she is, I would say, a middle of the road, conservative, progressive person. And unlike her predecessor, Charlie Baker, she's not as tall as she is. And they both play basketball, by the way. But I would say Maura's focus is, again, more law enforcement, where Charlie Baker was really more management, if you will. It'll play out with the governor what her legacy is in terms of what she looks at and what kind of legislation she either supports or presents herself. Senate President Karen Spilka, she's from Hopkinton, very influential person, obviously, in the Senate. And in the House, probably one of the most powerful people in the state, I would say slightly more powerful maybe than the Senate president, is the Speaker of the House, Ronald Mariano, and he's from the city of Quincy. There's about 51 standing committees in the legislature. 29 of them are joint committees. So there's committees are really the place that that legislation gets boiled down, that really gets reviewed, vetted. It's an opportunity for the public to come in and comment on various bills. Legislators as well will testify on bills. The committee will review the merits of a particular bill, and they will vote as to whether that bill should continue in the process or not. If a bill doesn't make it through committee, then it's effectively dead. A bill can make it through the committee, but still not make it through the entire process. There's then a series of steps that it has to go through. But nevertheless, all legislation that gets filed back, as I said, in January, gets assigned to a committee. And when that bill is assigned to the committee, then the committee will have a public hearing and they will review it. There'll be back and forth. There'll be opportunities for people to meet with committee members. So typically it's the vice chair and the chair that really do the bulk of the work, and their staff. The committees that are important for pharmacy, and again, what I'm focusing this conversation today about is really, what's important to us and what's going on in the system. The Senate Committee on Ways and Means, a very powerful committee. It determines what bill comes and goes in the Senate. The chairman of that is Michael Rodrigues from Fall River, actually from Westport. The House Committee on Ways and Means, the chairman is Aaron Michaelwitz. Aaron is from Boston. Again, very powerful committee. Those two committees really control, they're sort of the traffic controllers of all legislation, whether it gets to the House floor or whether it gets to the Senate floor. The Joint Committee on Healthcare Finance, any bill that's related to healthcare and finance will go to this committee. So again, obviously, there's a lot of business interest in this, a lot of things like payments for Mass Health, payments for insurance and so forth. The Joint Committee on Financial Services, which is, I should go back here, the Joint Committee on Healthcare Finance is chaired by Senator Cindy Friedman, and the House Chair is John Lawn. And moving forward, the Joint Committee on Financial Services, again, this committee looks at insurance issues. So a lot of the focus on the PBM issues is starting on the Committee on Financial Services, and then it'll move forward to the Committee on Healthcare Finance. And then last but not least is the Joint Committee on Public Health. That's chaired by Senator Julian Cyr, and the House Chair is Marjorie Decker. Public Health will look at pharmacy practice. Generally, the scope of practice issues will be assigned to this committee. And that's they're the people that will vet the legislation initially to determine whether it has merits or not. So that's sort of a layout of the land, if you will. The 2-year session, you have to get a bill in by January. The first session, it's got to go through the committee. The committee has to vote on it. Once the committee approves or disapproves, if they approve, the bill moves forward, and you have about a year, maybe 10 months to get the bill through the system, finally to get to the governor's desk to get signed. So it's, if you think about, there's about 7,000 bills, about 100 of them relate to pharmacy, as I said. There probably will be 250 bills that actually pass the process. So it's a tough fight. Typically, a bill, once it's filed, takes almost between 7 and 8 years on average to get through the legislature. So it's things don't get fixed quickly in the legislature. But as we mentioned earlier today in the Board of Pharmacy presentation, the statute and changes in the law are really what drive ultimately the professions through the regulatory process. So once a new idea is hatched through legislation, it's implemented through regulation. But regulation cannot create a new law. It has to go through the legislature. And of those 160 House members and 40 Senate members, those 200 members in total, there's not one pharmacist there. There's zero number of pharmacists in the legislature. So we have to, we being, the organizations that represent pharmacy in the state, we have to educate not only those 200 legislators, but their staff, and their staff can be 4 or 5 people. So it's a daunting task to educate and let people know, number one, what pharmacy is, what pharmacy is all about. We have to, a lot of legislators have no idea that a pharmacist goes to college, that there's training, that there's specific degrees that are associated with pharmacy, that pharmacy is an advanced degree, that pharmacists are trained in practical as well as didactic skills. Many legislators think of pharmacy as CVS, and because that's their experience. And so our job is to educate about the profession, is to educate about all of the nuances about the profession, and convince legislators the importance of pharmacists and the role they play in healthcare. In that effort, one of the things that we did 2 years ago now is we created a pharmacy advocacy day at the State House, and it was a virtual event. So as post-COVID, a lot of people were squeamish about going into public areas and public arenas. The State House was closed for a great deal of the COVID pandemic. So the use of remote programs like we have going today has become quite common with dealing with legislators. And so many of the meetings we have now with staff, many of the meetings we have with legislators are remote. We still now, more than before, it's beginning to pick up. More and more legislators are having face-to-face meetings at the State House. But for the past 2 years, we've done a remote program in October related to the Pharmacy Recognition Day in October. Pharmacist Month is October, and we did a program in 2022, and in that program we asked the 2 hosts of our Pharmacist Day, Senator Jamie Eldridge and Representative Alan Sylvia. We asked them to host the program. We did various presentations by the Mass Pharmacist Association, the Mass Independent Pharmacist Association, the Mass Society of Health Systems Pharmacists, the Mass Chain Drug Council, the Colleges of Pharmacy, and all of the presentations were and relative to a particular practice area of pharmacy. And so it was an opportunity for us to talk about our profession directly with legislators who were invited by Senator Eldridge and Representative Sylvia to participate in the programs. Out of that event, out of that effort, we developed and built a pharmacy caucus. And a pharmacy caucus, you've probably heard more than you want to about the Iowa caucus, and you'll be hearing about the Nevada caucus. But a caucus is really an organization of like-minded people within the legislature. It's an organization of legislators. It's not an organization of pharmacists. And it's legislators who have a particular interest in pharmacy. And that the reason we did that, the reason we wanted to pull that together is, just as I mentioned earlier, it's a daunting task to teach and to meet with each and every legislator. But if we have a group of legislators who feel strongly about our issues and are willing to advocate for us within the State House, it adds to our lobbying effort at the legislature. So we felt it was very important. And as I mentioned, Sardino and Tom Pasternak are two key pharmacists who had relationships with these legislators, who brought them to the table and helped facilitate them. Now being the chair, the Senate chair being Jamie Eldridge, and the House chair, Alan Sylvia from Fall River. So once we form this caucus, the next step in the process is then what are the issues that we want to focus on? We know, amongst pharmacists, we know that there are a lot of issues. There are a lot of things that we're concerned about. There are a lot of things that we'd like to change, but we need to. We can't have everything. We can't be everywhere at all times, whatever that movie's name is. And the thing that we wanted to do is identify amongst ourselves, amongst the pharmacy community, and then present to the caucus what we thought the caucus should have as priorities, and then that match to either existing legislature or future legislation that we wanted to file. But the process that we followed was, I thought, very thorough, because we vetted amongst ourselves, amongst the pharmacy organizations that I mentioned. We looked at the highest priorities we felt. We boiled it down to a manageable list of, I think we began with about 12 priorities, and we then boiled that down to 5. And so those priorities are starting with the number one thing that I've certainly been working on, and that is PBM reform. The PBM issue is one that is very, very difficult for independent pharmacies. It's difficult for, I think, now hospitals are being affected by it. Certainly, any pharmacies that are submitting bills to PBMs who act as middlemen for insurance companies is put pharmacies in a very difficult spot. There are, within the PBM reform, issues that we focused on. For example, the maximum allowable cost, drug transparency. Many people struggle with compensation for generic drugs through the maximum allowable cost programs. And so we've spent a lot of time educating legislators as to what a MAC is and how it operates and why it's a problem for pharmacies. We also focused on mail order prescriptions, another area of a lot of concern by independent pharmacists, obviously. And we wanted to have parity in terms of, again, our position has been and continues to be that we don't oppose mail order, we just oppose mandatory mail order. And we believe consumers should make their own choice and not be forced or penalized to use mail order pharmacies. The next item on our hit list was to improve patient access and / health promotion. Essentially, that's the test and treat issue. And we believe that pharmacists as healthcare providers should be paid for those services. And we believe that pharmacists should be allowed to test and treat for selected qualified conditions, HIV, flu, streptococcal infection, and COVID-19, amongst a few. The third priority was ensuring pharmacists' practice requirements are current. That focused on the collaborative drug therapy management agreements that are currently restricting ambulatory care pharmacies to have on-site supervision. And we felt that is not in the best interest of the patients. So those were the priority issues that we wanted to focus on. And within the PBM reform legislation that was brought forward in the Senate this year, we worked with the Senate. We worked with both the House and the Senate, I should say. And they have priorities that we're working on in terms of current legislation. Senate 2520, which is a pharmaceutical access, cost, and transparency, PACT, P-A-C-T. So Senate 2520 passed most recently in the Senate. It would register and regulate PBMs. It would require PBMs to report to the Healthcare Policy Commission. The Healthcare Policy Commission we'll talk about a little bit later, but it's a state agency that collects health information and monitors trends in rising costs amongst either hospitals, right now mostly hospitals, and it would expand, this legislation would expand that reporting to insurers, to PBMs, and pharmaceutical companies. It creates important definitions regarding what a PBM is, what activities they are, and how they can be regulated, so that you couldn't operate in Massachusetts as a PBM and not register with the Division of Insurance. It focuses on specialty pharmacy, mail order. It focused on MAC lists, pharmacy appeals for MACs, and other payments. And it requires disclosure of MAC lists and allows pharmacists access to the MAC list so they can bill and understand what the payment is going to be before they're faced with a dilemma at the counter. They won't be able to identify and understand MAC lists before they fill the prescription. There's also a study in the PACT legislation to look at payment for pharmacists provided ambulatory care services. We fought hard to get that. There was an amendment into the legislation, and this is one of the first times really that the legislature has taken up as a part of legislation actual language in the bill that would compensate pharmacists for services, not for medications. And it is known as the Cost Access and Transparency Act. It passed the Senate in November of 2023, and it is now before the House Ways and Means Committee. So one of the things I did not comment on when I was talking about the process of filing legislation and having it move through committees and so forth. Things have changed in the State House in the process in both the House and the Senate over the, I would say probably again 5 to 7 years. Many issues such as the PBM reform and others, as we'll talk about today. Many of those issues are single bills that are filed for single particular issue. We have a bill that we filed specifically for relief on the MAC drug issue, and the bill was just dedicated to that. We filed it. It was in the Committee on Financial Services. But what's happening, a trend that we're seeing again over the past 5 or 7 years, is a lot of bills like that are getting blended into an omnibus bill. So there may be a bill filed somewhere in the process, but then later on, the committee may take up and say, all right, we're going to do PBM reform. Let's look at all the PBM bills and let's combine them into one mega bill. And that's the bill that will move forward. And as opposed to passing 7 individual bills on PBMs, we'll get one bill and combine everything. And that's really what the PACT legislation, that's really what the PACT legislation over here, it took a lot of these issues here that I just talked about were parts of individual bills that had been filed. We filed, in addition to the MAC bill, we filed a specialty pharmacy bill. And the specialty pharmacy bill that we filed was, it's been about 4 years. It's been, in the process. And it it defined a specialty pharmacy as not necessarily the specialty pharmacy that the PBM would like to see, but we filed a bill to have the Board of Pharmacy create a specialty pharmacy license. And within that license and within the regulations for specialty pharmacy, we would like to see a definition of a specialty drug. Now, as many of you know in the audience, some of you may work in specialty. Specialty drugs are generally ones that require monitoring, special packaging, special handling. They may be the result of a restricted distribution by FDA or some other process in which they truly are special. What's happened, however, in the insurance world is as the price of a drug gets to a certain price point, the PBM will decide that that drug should be handled as a specialty drug. And while that's all well and good, what happens is specialty pharmacies fall under a provision in the Any Willing Provider law that allows them to restrict distribution and eliminate distribution by other pharmacies, independents being the most common. So what happens as a practical matter is a drug, it reaches a price point where the PBM decides that that drug should be now a specialty drug, and pharmacies in the network can no longer dispense it. It has to go through the PBM's affiliated specialty pharmacy. And it's really an economic issue. It's not a safety issue. It's not, really what the specialty pharmacy was intended to do, which is to distribute under very specific guidelines. So long story short, we had a separate bill filed for specialty pharmacy, but it got combined with our MAC bill. It got combined with some other bills, some other legislation, and it got created into this PBM reform legislation, Senate 2520. And the good news for us, I think for pharmacy this year, is the Senate had actually passed this, an initiative like this for 3 straight sessions, and there was never any action in the House. And this year, unlike all previous years, this year there actually is going to be action in the House. And we believe that this year, we're very hopeful, very optimistic, that there'll be a House bill, that there'll be a conference committee, and the conference committee takes a bill that went through the Senate, and it takes a bill that went to the House, and the conference committee will work through any differences, come out with a compromise, and hopefully once that happens, it's pretty much a slam dunk. It goes through both chambers, and it would get before the governor for signature. And again, hopefully we don't know for sure where Maura Healey stands on PBM reform. We presume that she would likely sign it because of the work done by the Senate and the House. But we certainly would like to get to that point and get to that point this year. Another whole group of things that were filed this year were what I call scope of practice. So the other initiative here, as again was a priority of the Pharmacy Caucus, was the test and treat initiative was filed by MSHP, House 4066 and Senate 1425. This would allow pharmacists to screen, test, and treat qualified conditions while receiving much needed reimbursement. And this is, I can just tell you, this is one of the only pieces of legislation, other than what I just mentioned, the study within the PACT legislation. But this particular legislation is one of the only bills where pharmacy scope of practice has been modified, and there's a specific language about pharmacists needing reimbursement as a result of it. There was a public hearing on this September 12th, 2023, before the Joint Committee on Financial Services. This allows testing by a pharmacist or technician, provided the pharmacy has received a CLIA waiver, clear waiver, and prescribing for treatment of selected conditions. And the specific language says that the insurance company shall develop adequate procedure codes and consult codes for pharmacy compensation. So this bill, it's his first year, and it's the first year it's been filed. It received a lot of support. It received opposition from the Mass Medical Society. Surprise, surprise. But it is, I think, landmark legislation, and hopefully Massachusetts will become like several other states, one that will provide a compensation path for pharmacists, and not just dispensing medications, but for pharmacist services, either as pharmacy, pharmacy providing services through a pharmacist, or pharmacists as individual practitioners. Another piece of legislation related to our priorities in the Pharmacy Caucus is an act relative to collaborative drug therapy management optimization. What happens right now is, you probably know that collaborative drug therapy management's been around for a while, probably over 10 years. And there are many pharmacists that are participating in CDTM agreements in various settings. But there was within the regulation and within the law a provision, for whatever reason, maybe an oversight, but nevertheless, that pharmacists in the ambulatory care clinics, ambulatory care setting, need to have on-site physician supervision. And that is very, very awkward for pharmacists practicing in an ambulatory care setting. So this legislation tweaks the law, tweaks the CDTM law, and it makes it the same as other settings, such as hospital, hospice, or community pharmacy, and it would not require on-site supervision by a physician, especially in those cases where a pharmacist is in multiple clinics. It is really very, very awkward for coverage by an on-site physician. So this is another priority of the caucus, and we're hoping again that will prevail on this issue. The primary goal, I think, of what we're doing in terms of looking at our profession, a lot of people are very nervous as to what the future may hold for pharmacists. We heard from a couple of speakers today in terms of the breadth of knowledge that pharmacists bring to the table, whether it be in disease management for diabetes, or whether it be for ADHD, or even artificial intelligence, as we talked about. The great potential that pharmacists bring because of their knowledge and their education is in many regards a lost opportunity. And at the same time, pharmacists are looking at the future. And we have a lot of things going on in our profession that are good. As again, we heard today, the types of medications that are in the pipeline, the types of things that are in the future, the things that pharmacists may be doing with AI and so forth. But unless we have compensation and an adequate compensation, there's no true way for us to support that. So we wanted to look at, and I wanted to look at today in this presentation, what has happened with scope of practice over the years. And when did we really start, looking at that? When did it start changing, and where is it going? And what is it going to mean for most pharmacists? So we have, for example, the collaborative drug therapy management. That all happened, that began in 2008 with legislation that passed back then to initiate, for pharmacists to initiate treatment, to modify treatment, and to provide, above and beyond what a pharmacist typically does. And it was interesting back, when I remember lobbying on this issue, the thing that really made the medical society, sort of eliminate their opposition was when it really crystallized on them that they won't have to get all these phone calls from pharmacists anymore to change the therapy for Coumadin. If there's a change in the patient's INR, we can have an agreement with the pharmacist and they can make the adjustment to the dose and they don't have to call you. And, once physicians really began to understand them, I mean, it was a very simple issue, but it was very valuable to them because of their time and their effort. So the beginning of all of this was, pharmacists can do more things and make life easier for the physician. That was the cry. Years later, pharmacists were allowed to administer vaccinations. That happened in 2015. It was done by a joint policy between the Board of Pharmacy and DPH, Joint Policy 2015-01. So it was COVID-19, shingles, and other vaccinations based on the CDC guidelines. And again, pharmacists stepped into a role that was different than what they were doing before. I think people, have had mixed emotions about this, whether this is a good thing or a bad thing for the profession. But nevertheless, it's here, and pharmacists are engaged in it. And clearly, the role and the value of pharmacists came to the forefront clearly in the COVID-19 pandemic. The next thing along the line, again, through circular letter, but actually it was a modification in the legislature as well. But pharmacists may administer mental health drugs. There are a certain list of drugs that pharmacists can indeed administer as part of their scope of practice. Trying to get cut off here on my screen. 2021, the telehealth bill passed. And in that telehealth bill, a lot of people don't realize this, but as of that legislation in 2021, pharmacists were added to the list of providers recognized as healthcare providers in Massachusetts. So we became providers. People say, well, we're not recognized. We are recognized. We are recognized as healthcare providers. The problem is we're not paid, but at least in terms of the law, back in the telehealth legislation, pharmacists were added to the list of Department of Public Health recognized healthcare providers. And other legislation, other laws, and so forth and so on, refer to the chapter in the public health laws that list healthcare providers, and pharmacists are there. Again, as I said, our next role really is to try to find a compensation process. In 2022, Chapter 127, pharmacists were added to emergency contraceptive care, and pharmacists were authorized to prescribe emergency contraceptives. That was following the Roe versus Wade decision, and the federal government, states began to sort of prepare, if you will, for other states sending patients here through their restrictions. Other patients may be coming to Massachusetts, and the governor at the time and other members of the legislature wanted to make sure that there were adequate people to provide emergency contraceptive care. In 2023, just last year, in the state budget, the annual budget, section 42 authorized pharmacists to prescribe oral contraceptives. And that was signed into law in July 2023. And actually, both of these bullets, the emergency contraceptive and the pharmacists prescribing oral contraceptives, both of those issues were talked about earlier today with the Board of Pharmacy with one of their advisories. And so pharmacists have clearly been recognized by the legislature already, and their scope of practice has been modified. The interesting thing is we being the pharmacy community, we were not involved in any of these discussions. The legislature just went right ahead and did this and said, okay, pharmacists, as of July 2023, you can now prescribe oral contraceptives. Well, that's wonderful, but what about the time that it takes for the pharmacist to evaluate the patient, provide all of the necessary counseling to the patient, determine which product the patient should get, and all of the reporting that is then required by this regulation and this law? There's no compensation for the pharmacist services to do that. As a result, quite frankly, I don't think there's been a lot of uptake in terms of pharmacists doing this. It's more work, it's more liability, and there's no pay. And that's the point we make continually with legislators is we need to have a compensation program before any of these initiatives are really going to take off and work. A couple other examples of what's happened, what's happening at the State House Senate 1353 is an act enabling pharmacists to prescribe, dispense, and administer PrEP, which is the preventative drug for HIV. It passed the Senate in October 2023. Everybody congratulated everybody. Here's a new bill. Isn't this wonderful? And again, I had the conversation with Senator Sear. Senator, it's a great idea. It's all good. We support it. But you're asking pharmacists to do this, again, take on the liability, take on the cost, the time, the record keeping, and so forth and so on, with no compensation. They said, well, you get paid for the medication. And I said, well, we get paid for the medication anyway. It doesn't matter, and prescribing and doing all these other things. A doctor doesn't do that for free. Why do you expect a pharmacist? Senate 1435 and House 2184, an act authorizing pharmacists to provide opioid use disorder treatment via CDTM. Now that bill is still in committee, and that's again another bill that expands the role of the pharmacist through CDTM, similar to the modification of CDTM on supervisory issues. This adds opioid use disorder treatment to the breadth of conditions that a pharmacist can be involved in. And last but not least, House 4066 and Senate 1425. Again, we talked about this previously. An insurance carrier and a PBM shall develop adequate provider and consult codes as authorized by this act for pharmacy compensations. Health plans shall be prohibited from denying reimbursement to services and procedures performed by pharmacists. So House 4066 and 1425, the test and treat bill, had and has specific language that would compensate pharmacists. The PrEP Act here, as I mentioned, this did pass the Senate. It went to House. It's in House Ways and Means. It could pass. I haven't had a lot of feeling that this has got momentum, but it could pass because it's already passed half the body in terms of the Senate. It allows pharmacists to prescribe, dispense, and administer HIV preventative drugs. It may not furnish a 60-day supply in a single patient more than once every 2 years. Allows the pharmacist to order and test HIV. Requires the pharmacist to notify the patient's primary care. This is good because, and good, I'm saying ironic, is that now the pharmacist does this, but then the pharmacist is required to work with the patient to contact the patient's primary care provider. And if the patient does not have a primary care provider, the pharmacist is required to give a list of primary care providers to the patient for them to choose. And to do all that, no compensation. And I said to Senator Sear, great idea, but it's not going to go anywhere. House 1435, Senate 1435, House 2184. Again, this is a bill that would expand the pharmacist to prescribe drugs in Schedules 2 through 6 for the use to treat substance use disorders. It's specific for that diagnosis. A copy of the prescription shall be sent to the supervising physician within 24 hours. It's a good law because it's necessary, because many patients are not getting the adequate treatment for substance use disorder. And it's, Suboxone and other products like it. Again, with no compensation, the likelihood of many pharmacists doing this is not great. And again, these are examples of time and time again where pharmacists are called upon to do things beyond the scope of practice, to really revise their scope of practice, but without adequate insurance, primarily insurance compensation. In the bill that we talked about, the PACT legislation, Senate 2520. Again, this bill passed the Senate, it's in the House. There is a particular section 64C, and it says that the Healthcare Policy Commission, in consultation with the Board of Registration and Pharmacy and the Division of Insurance, shall study and analyze the performance of pharmacists of primary care functions within their authorized scope of practice. So this was a section that was filed by Senator Bruce Tarr, and with our help. And what it does and what it would do is the first time ever that the legislature will take up pharmacist compensation for all of those things that I've just talked to you about, all these initiatives, all these bills. And now we have a specific bill with specific language that says, okay, let's look at what we've asked pharmacists to do. Let's look at how they get compensated for this. Are they doing it? Is there any benefit? Are patients getting access to these services? And so this could be really huge legislation in terms of moving us towards compensation for services and for expanded roles and expanded scope of practice, and finally getting the recognition, which is really what provider status is all about. So we feel, again, it's an uphill climb. There's a long way to go. We still have a whole year that we have to get through, and we're not exactly sure what's going to happen. You never know. Things, what's going on with Stewart Health now with the hospital destabilization, that could take a lot of oxygen out of this, the momentum that we've got. We are getting good vibes from a lot of different people about PBM legislation. The House, as I said, for the first time ever, has taken up PBM reform. And Chairman John Lon has been working very closely with us on language and on the initiative. He feels very strongly that the PBM industry needs to be reined in. So let's just hope that it happens. Very quickly, the Health Policy Commission, again, another agency that looks at cost trends within the Commonwealth. They have taken up and looked at pharmacies. And what one thing they have found is that there is a huge problem with inner city pharmacies, and that Health Policy Commission has also recognized that compensation to pharmacies is a big part of why there is a huge problem. They're showing that in Massachusetts, there are fewer Black pharmacies in Black and Hispanic Latino neighborhoods. And this was all before we heard that the Walgreens pharmacies were closing down and moving out of the city. So we are really interested in working with the Health Policy Commission. Another interesting thing we found in one of their studies, in one of the called the HPC data point, is that pharmacy, when flu vaccines were given in a hospital outpatient department, it cost $108. When it was given at a physician's office, it cost $56. And when it was given at a pharmacy, it cost $28. And, we may say, well, great news, send all your patients to pharmacies for flu vaccines. But what this really illustrates is that pharmacies at $28 are being compensated by PBMs and should be at least making $56, if not more, in terms of the very same service given to the same patients. And we are working with the Healthcare Policy Commission. A very brief note on out-of-state pharmacies. I had a big presentation here, but what I'll tell you is out-of-state pharmacies are going to begin to be regulated. There's going to be a public hearing on February 28th. And that public hearing is going to be focused on licenses, permits, and services to be charged by state agencies. And once this is done, once this regulation passes, the board will finally move forward after 10 years and get out-of-state pharmacies registered and be part of the regulatory oversight of the Board of Pharmacy. Last but not least, there's 11,000 pharmacists in Massachusetts, and about 7,400 of them are working. And Massachusetts is among the weakest states in terms of professional associations in the country. The current trends in working conditions and primarily in chain pharmacies has led to walkouts across the country. Pharmacists are very, very unhappy in some of these settings. The issue of vaccinations is controversial. People have burnt out through the COVID pandemic. There's a lot of unhappiness out there. And the US Bureau of Labor Statistics predicts a 10% job loss in retail pharmacy over the next 10 years, or by 2032. So the future of pharmacy for a lot of pharmacists is not great. And unless we can get these things to change at the legislature, unless we can get paid for services, for scope of practice, unless we can make that all happen, we're really not going to be able to move forward as we could as a profession. So get involved, join a trade group, find out who represents you, reach out to your elected representative, let them know who you are, support candidates, get involved, carry signs, collect signatures, whatever it takes. Get involved in the community, be on the school committee, the board of health, whatever. Get involved, because if you're not involved, and you got to be at the table or you're on the menu. And that's really where we want to be in terms of pharmacy involvement. So I'll let it go with that. And if there are any questions, let's see.